Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision, the standards, and the culture of healthcare systems. If you want to join in the conversation or learn more about activating physician leadership, go to license2leadpodcast.com, where you can send me an email or even leave me a voice message. I'd love to hear from you. Hello, everyone. Welcome to the License to Lead podcast. I'm Patty Fay. My guest today is a two-time Emmy award-winning filmmaker, Robyn Symon. Robyn has written, directed, and produced films and television series, and she specializes in documentaries. So Robyn is currently on an international film tour with her documentary about physicians and medical training, and the film's called Do No Harm, with the subtitle, Exposing the Hippocratic Hoax. It's about a sick culture in medical school and residency that drives depression and burnout and suicide among medical students and physicians. It's powerful and it's phenomenal, really, for this issue, which is so important to physicians, to attract a filmmaker of Robyn Symon's caliber. I recently watched the film and the panel discussion afterwards. It is so powerful, and it's directly related to the purpose of this License to Lead podcast: the commoditization of physicians in the big business of healthcare, lack of physician autonomy, and the need for physician leadership. I am so happy to welcome Robyn today to talk more about this important film, Do No Harm. Robyn, welcome.
Thank you, Patty. It's wonderful to be here. It's a very important topic right now, of course, with COVID-19 and healthcare workers being on the front lines and, finally getting the respect that they deserve. When I first started the film in 2014, people were like, why are you doing a film about doctors? Aren't they playing golf all the time? And, why should we care about them? They have a great life. And besides that, they keep me waiting, and I don't even know what doctor I'm going to see when I go to the doctor's office. So there was all this anger and angst, with physicians. So I'm happy to see, although unfortunately, under these circumstances, but physicians and all healthcare workers finally getting the appreciation, respect, and admiration that they really deserve, because they're really trapped in a very toxic healthcare system that patients don't realize it's not under their control. And they're just as frustrated and disillusioned as patients are.
Is there something about the medical world that particularly attracts you, or something about your background that makes this of special interest to you?
Yes, I come from a family of physicians. My grandfather was a family doctor. My uncle was a colorectal surgeon in New Jersey for 30 years. I have two cousins at the Cleveland Clinic. So, these people were like the rocks of our family, just available all the time, never complained. And they were just, so when I heard in 2014, someone had sent me an op-ed piece from the New York Times about these two young doctors who jumped from the roofs of their hospitals within a week of each other. I just, knowing what I know from my family, how stable and this large capacity to, hold so much inside, I just couldn't understand why these brilliant young people would logically think suicide was an answer to their problems. How trapped they must have felt. So I was just drawn to a journey to find out why this was happening. And not just that, but what's the impact on patients as well.
Right. So as the producer and director of this film, and with this interest in trying to get to the bottom of what's going on and what's the impact on patients, what would you say is your message with the film? What outcome are you looking for or hoping for?
There are many messages of the film. But one message is that physicians and patients must unite. They have to be on the same team in the face of what we see as the corporatization of healthcare. We have to take it back together. And it's really only going to be together that we can really make a difference. We can put pressure on Congress, our local legislators, so, even our clinics and CEOs. We can attract the media. There's a lot we can do together. So that's the most important message of the film. We must be united. Another message internally for physicians is that it's not you. You're not the problem. It's the system. We have to change a very toxic system that starts in medical training. So you're not the weak link. And it's the system that needs to be changed, and we can do it together. So I think those were the important messages. And then the stigma of mental health, since, May is Mental Health Awareness Month, it's important to remember that suicide in general, there's a stigma about mental health. But for physicians, it's even worse because physicians are supposed to be tougher than that, show no weakness. Yeah. So we need to address this stigma that has long plagued physicians, and not just the stigma. There are real world consequences for getting mental health counseling, consequences to your career if you're a physician that everyone knows about with the licensing board, how questions in many states still remain, have you ever sought mental health counseling, which is very discriminatory.
Yeah. And can you talk more about maybe what some of the members of your audiences or maybe even one-on-one conversations, what you've heard about the stigma and that barrier to getting some help when help is needed?
Well, it's huge. I mean, the consequence of that is, not just bad for the physician who can't get help and they wind up self-medicating because that's the only way they can cope with what's going on, whether it's losing patients or, dealing with a lawsuit. And they don't feel that they can confide in their colleagues because of fear of retaliation. But we also have to think about the impact on patients. If physicians feel like they can't get help and they're not functioning at their best mentally and physically, what kind of care are you going to get as a patient? So this is something that's important to everyone, not just the physician population.
Absolutely. And we know when somebody is in a threat state, when they are, feeling attacked or feeling under pressure or burned out, that basically the prefrontal cortex doesn't work as well. Physicians don't have access to the very best part of their brain. And we know through med school, empathy levels drop. And the rate of empathy that physicians experience in interacting with patients tends to decline through every year of medical school. Yeah, what you're saying about the impact on patients, I think, is just absolutely huge. And have you noticed any initiatives or anything that has changed? Any place that has just grabbed hold of this idea that we've got to do something about having a lower threshold for trainees, medical students, and residents to be able to get into some mental health counseling?
Well, there's been a lot of grassroots efforts, and I think it's really sparked by social media. Mm-hmm. Luckily now physicians, especially the younger physicians, can communicate with each other and can create a sense of community where, maybe at their own hospital or medical school, they just didn't feel like they could, but somehow online where there's some kind of anonymity, they can feel free to reach out and connect with others. So I think that's incredibly positive. And I think social media will be a big part of the change that we're going to see in our culture, in the medical culture.
I think when I was a medical student or resident, it would have been inconceivable to share some of these ideas and, some of the stressors. There was a shame associated with experiencing any stress with going through the process of medical school. And is that a word that has come up for you with some of your audiences, the idea of shame?
Absolutely. Absolutely. I mean, before 2014, when I started this, I remember being told that there were conferences where they would try to do a seminar on physician suicide or depression, and they would only get a few people to attend. Nobody wanted to be, sitting in that room. We don't need this. Right. So even if they were suffering tremendously, they wouldn't show up. But since 2014, we see this topic come up at conferences more often, and we see a higher turnout. So even for the film, as I travel around the country, we see, packed audiences of administrators, med students, residents, faculty. They all want to talk about this now when it was such a taboo for decades. So I'm encouraged to see this level of participation, this willingness to talk about it in public, especially.
It is fascinating that, I think the film has a lot to say about the dysfunction in medical school and residency. Mm-hmm. And yet that's the forum, really the venue that you're taking the film into. And can you talk more about that? Have you run into resistance, or has that shifted at all?
When I finished the film, Patty, I didn't know if I would be sitting in my living room alone with my film and have no audience. Because, the medical field, there are a lot of people who are very resistant to change, not even wanting to admit that there's a problem. They may have even known. I haven't met one physician who doesn't know at least one colleague who died by suicide.
Right.
So even though they know someone who's suffered, they just don't want to admit that it's a problem. And so, I'm surprised that we've had so many screenings. I mean, we've had over 180 screenings of the film, and it hasn't even been released to the public. This is just at medical schools, hospitals, and conferences. But, unfortunately, there are some schools and hospitals that where the physicians themselves or the med students desperately want to bring this film to their school or hospital to use it as a tool to open a dialogue. Administrators at some places are very resistant, and they unfortunately have the power to say no.
Yeah, I remember, I think when I watched the film from about 10 days ago at that Sunday night screening, I believe you were all lined up to go to Mayo Clinic, and somebody put the kibosh on it. Am I remembering that correctly?
Yeah, Mayo Clinic, Cleveland Clinic. I mean, these are places that you would think would be open to more physician participation and community. And at both places, there was so much interest from physicians in bringing the film there. But it was at the board meeting at both places that there was one person who felt that either we'll handle this in a more positive way, we'll do things our own way, or we don't need this. Some of the Ivy League schools, like Harvard and Yale, even Stanford, so many people have seen the film individually and want to bring it there, but there are some that just don't. And if they have the power, they can prevent everyone from seeing the film. And you know what I tell these administrators, Patty? I say, look, everyone is going to see the film eventually when it becomes available to the public. But isn't it better to watch it as a group in community so you can discuss afterwards about what you're doing proactively to improve wellness. Isn't that better than having someone watch it at 2 a.m, after a long day of rounds and seeing a film that, it's quite emotional?
Yes.
So if you really care about your community and they're going to see the film anyway, isn't it better to use this as an opportunity to showcase your team as being leaders in wellness?
Right. Putting yourself on the map as trying anyway to get ahead of this thing and have a voice for change when it's such a dire situation.
Right.
I think the dysfunction in medical school and residency and the harm done to these terrific people who are pouring their hearts into this. I think the harm done is immense. There is a certain irony with I guess specifically with the Mayo Clinic and Stanford, does a lot of research, does a lot of publishing, I should say, on the topic of burnout. So that is unfortunate that you weren't just welcomed with open arms.
They know me. They know about the film. They know how to reach us. Mm-hmm. So, Tate and, everyone there. I mean, I'm sure he knows about the film, and as do many administrators. Many have seen it,
right?
Individually. Many physicians there, and even the media department, I showed it to them, and she wrote a glowing email to me. This should be part of our curriculum and all of this. And then momentum just sort of,
fizzled.
Faded. Yeah, and some administrators, want that. People come into the office of administrators with all this passion and determination to bring this film in, to create this community event. And then, they hope it just fizzles out over time and people get busy, distracted with work, and they'll forget about it.
Right. It'll disappear. I know one of the comments that Pamela Weibel, Dr. Weibel, made was that if everything in this film and all the discussions and the real message of the film, if it was heard, it would bring the medical system and medical schools to their knees. And what do you think about that? I mean, what do you think needs to give? What needs to dramatically change in, for instance, the medical schools?
First of all, I really think that it has to be the public that is aware, which is why I'm looking forward to this film finally being on PBS in September. And also we've just made a deal with PBS internationally, which is called APT Worldwide, to share the film with public audiences, TV stations around the world, because it really will take public pressure to say to their lawmakers, wait a minute, how many hours are these physicians working, and how many medical errors are caused each year? Wow, there's a safety issue. We need to address this. And you saw the film, Patty, so back in 2003, 2004, there was a lot of concern on the behalf of the public to make changes in duty hours and to address the problem in some way because of the high rate of medical errors.
Right.
And at that time, what happened was the ACGME, which is, in charge of graduate medical education, they're in charge of residents.
Right.
At all the teaching hospitals. They came in and said, before Congress was going to act and, impose some restrictions on duty hours, they came in and said, no, wait, we'll handle it ourselves. We will monitor and take care of this. So Congress said, okay, you got it. And
what's happened? Say more.
Well, I mean, Are you familiar with the Libby Zion
Yes.
case that happened? Okay, so as a result of that case in New York, work hours were restricted to 80 hours. I mean, 80 hours a week, which is
hours.
like double what normal people work, and they're tired when they get home. So you can imagine young doctors were working 100+ hours a week, but that was restricted, even though they really didn't follow it that well, but that's another story. But the ACGME was forced to impose this 80-hour work hours restriction nationwide, but it really wasn't followed very well. And part of it was the programs themselves, needed these young doctors to work more because after all, they're cheap labor.
Right.
So there wasn't a lot of incentive for anyone to really adhere to this guideline. And then not too long after I started shooting the film, the ACGME actually increased work hours for interns, which are first-year residents. 28, it was 24 plus 4, 28-hour shifts for interns. Now, what's wrong with this? Well, when you're an intern, you're now seeing patients in a clinical setting. So if you're not really supervised well and you're exhausted and sleep deprived, you're going to make mistakes. So they are actually, and we talk about it in the film, these young interns and all residents are being set up to fail, set up to make mistakes that could injure or kill a patient, something that they would have to live with the rest of their lives, not to mention being, party to a lawsuit. But, there have been a lot of studies about sleep deprivation and how after 16 hours, you're not functioning as well as you should be, as well as patients deserve you to be functioning. So imagine you're new in this clinical setting, and now you're forced to work 28-hour shifts. I mean, who does that serve? So maybe, the ACGME shouldn't be responsible for overseeing these duty hours. It's a complicated, problem because they're dealing with hospitals too. And these hospitals are saying, look, we need these people to work. We can't be hiring new residents. We don't have the money, even though many hospital CEOs make, $10-12 million a year, but they don't have the money to hire new residents. So, we need to keep these hours long.
It is I think it's not even a secret that it's, residents are cheap labor, and the economics of the hospital can really rotate around having that cheap labor available. And I think one of the things that I read about the duty hours when they had been limited, I think, as you said, to 16 hours and then increased it. And they studied that, as I understand it. And it turns out that, there were no real detectable differences in errors or whatever it was that they were measuring. But the underpinning fact is that all they did was compress the work. So it was the same amount of work compressed into the 16-hour shift. And so it was actually easier when they opened it back up so that the interns could actually, have a few more hours to get their work done. But the point is they shouldn't have that much work. They should have the amount of work that they'd be able to safely do in a 16-hour shift.
Imagine being a pilot and being told, well, we have to reduce your work hours, but you still have to fly, the same number. You still need to fly the same number of flights, but you just have to do it faster because, these people have to get from here to there. These operations have to happen. These people need to fly. So we have to reduce your work hours, but you're still going to have to get these people from here to there. I mean, it makes no sense. Yes. And also, Patty, the study that they use to cite that there was no impact on mortality of patients when duty hours of residents were measured, it's because it was a completely faulty study, because what they measured was work hours of residents on the mortality of patients, right, after surgery. Why don't they measure, or why didn't they measure, things that really are influenced by duty hours and sleep deprivation, such as how many car accidents did residents get into on the way home from work? What about, just diagnostic mistakes that they made?
Absolutely.
Charting
errors.
Charting error. Why not just measure that? Why measure mortality of patients from surgeries?
Robyn, I can remember driving home when I was doing my residency, and I would put my car in park because I would so often fall asleep at a light, and I would put it in park so I wouldn't roll into the intersection,
right.
But I would drift. I would drift off and jerk back awake again, or somebody would honk at me.
Isn't that crazy?
Yeah.
And you just took care of patients.
Absolutely. Yeah. And would be heading back in, soon thereafter. And I think that's something in your film too. You made such a point about issues with sleep deprivation. I think it was a Harvard sleep expert that you had in the film. Is that right?
Right. Yes. 2 of them. Mm-hmm. Mm-hmm. Yeah. Who've done many studies. And, the other side of that is that, administrators will say, and even, the president from the ACGME would say, well, you need to learn about continuity of care. So that's why you need to work these long hours. But if you talk to residents, they're really doing scut work during that time. They're not really, following patients. They've got 40 patients. You're not really following patients that well, that you're learning. You're not really in an optimum learning environment. No. And you saw in the film, these young residents and med students suffering from seizures. And there are many other, health problems that result from sleep deprivation. So what kind of foundation, are we building here with the future physicians of tomorrow that they come out of med school, physically and mentally just destroyed?
Yeah, absolute. Yeah. Harm is done. And I think that the idea that the justification for ungodly long shifts, 36-hour shifts, that seems quite disingenuous. That it's all about continuity of care. That one doesn't pass the sniff test, I'm afraid. Mm-hmm. So good.
I'm glad you see that, because it's hard to convince some people.
Well, and I think, as you mentioned, it's cheap labor, and I guess it would be tracing what is the incentive, what's the motivation for the ACGME to be, so dead set on protecting the hospital's interests.
It's financial. You really have to follow the money in all of this. It's so many hospitals are closing in rural areas. There are problems. Just like there are doctor shortage problems, because physicians are becoming so disillusioned with the system that they want out. They want out at 40 years old. Not only is that terrible for patients who can't get an appointment with a physician, but we're losing our mentors. You as a physician know how important mentors are. The medical field is a mentor-based, field. Back in the old days, you would follow around a physician and learn the trade. That's how you learned. We're losing our best mentors. If they're quitting at 40 years old, who's training the young doctors coming up? So it's a huge problem that needs a lot of attention.
Well, and that physician that leaves at age 40 or age 50 really left a decade before, as far as, the capacity to be an excellent mentor. We can assume the burnout started long prior to that. And because there's a lot of inertia to stay in practice. There's a lot of, it's a physician's entire identity. And to give that up, that's not an overnight decision.
I'm sure
there's a lot of stress and just a lot of accumulated stress that would lead to somebody ultimately making that decision to leave practice altogether.
Not to mention the debt. So many physicians are still working off debt from student loans, 20 years into their practice.
And it's so much worse. I mean, now it's close to $500,000 now that many of these, people emerge from medical school with $500,000 in debt. And what have your audiences been saying about that, if anything?
Well, they just see it so clearly that they never realized, a general audience just never realized, that this was happening. And young medical students, they understand, they get it. You're 1 year in and you are trapped because you're now $50,000 in debt. And, what kind of career are you going to have that you're going to be able to pay off, $100,000 in debt? It's going to take you a really long time. So they feel like they're forced to stay, even though they feel completely disillusioned. The idealism that they had is just gone. In med school, when they're told, shovel them in, shovel them out, they're graded on how quickly they can get in and out of a room. That's not the idea they had when they dreamt about becoming a physician and worked so hard in undergraduate and their whole lives, since kindergarten. They thought they were going to have a wonderful relationship with their patients.
Hawkins really, exemplifies that in your film.
Yeah.
That expectation of having wonderful relationships with patients and then, finding the reality of medical school to be so different than that.
And it doesn't have to be that way. It can be a nurturing, wonderful environment. And in the film, you see at St. Louis University when Dr. Stuart Slavin was there, how he decided, to do a pilot project. And there were many things that he did, not costing a lot of money, that reduced the depression among students from like 24% down to like 6%, something like that. So, and it wasn't, complicated. It was a combination of what they're doing now of pass fail, the step one as a pass fail grade instead of, something that, could really scar you for the rest of your life and hurt any kind of chances of getting into the residency that you want.
Exactly. Mm-hmm.
So he did that, and he got rid of programs, classes that were just too tough.
Right. He changed them, right? He had them changed. He cut down on the number of hours of FaceTime that the faculty.
Yes.
Yeah. Mm-hmm.
He gave them more time off so they could do rewarding things in the community, get their heads out of the books. Mm-hmm. And then he did, a small wellness program, that was just, to supplement mindfulness types of things. But it was all of these things together.
Right.
Which is why I'm concerned, when you see across the country as I travel with the film at hospitals and medical schools, when they talk about wellness programs and they're talking about, yoga and meditation and things like that, when it's not one thing. It's really taking a hard look at your whole curriculum and seeing what needs to change. And they're afraid to do that because they don't want their students to be less competitive and to get into these great residency programs. So there's a real reluctance at medical schools to make the kinds of serious changes necessary to reduce depression. But you can see from this pilot program, it's possible.
It's possible.
Why aren't they doing it?
Right. And it's, you can imagine the deans of the medical schools are faced with this issue of feeling very pressured to make sure that their students emerge and can find residencies and their scores are good enough. But I think your point about wellness and the wellness initiatives is also true in organizations. So in healthcare systems where there's a 50% burnout rate, there are many things that structurally are causing that. I mean, that is burnout is a syndrome that is caused by the institution and by the dysfunctional culture. But even in those situations where they're not trying to prep anybody for grades and to pass tests, they go directly to the wellness programs, the yoga and incense and mindfulness and meditation, which can help anybody. But that's not treating the cause. That's the frosting on the cake. But even in those situations, we see so much more in the research about wellness programs as opposed to the structural changes and getting rid of the illegitimate work that physicians are doing day after day that's just grinding them down.
Right. I mean, you have to look at some solutions like working at the top of your license. So that means hiring medical assistants to take over some of the scut work that, you shouldn't be doing. So relieving those kinds of burdens would really help. I hate these Band-Aid approaches that even happen at the hospitals because they are worried it's going to cost them money. And it's interesting, Patty, they've done so many surveys and studies about how to reduce burnout. And you know what the most effective way to reduce burnout was in all these great studies that they've done? The number one effective way to reduce burnout. Guess what it would be?
Tell me. I have a lot of answers to that question.
The top, number one.
I'll tell you what I'll answer since you asked. The RAND study in 2013, AMA RAND study, showed that reducing barriers to physicians being able to provide high quality care to their patients was the number one thing that they found. Getting rid of barriers, allowing physicians to do their work so that they're not spending their time doing what I call the illegitimate work, which is way below their level, but it's taxing. It's neurocognitively extremely taxing to be clicking in, 5,000 clicks a day, which really would be the work of a data entry person.
Right. Yeah. That, to bring the joy back to medicine, to have it be more fulfilling. Well, what's fulfilling? Spending time with your patients, not, fighting on the phone with insurance companies.
Right.
And, doing, being at your computer. But that wasn't the number one way to reduce burnout.
Spill the beans.
Okay. Time off. Time off. That's all physicians really need. I was talking yesterday to an emergency physician at Coney Island Hospital in New York who's very much on the front lines of the COVID-19 fight. And he said, what they're doing is they're there are all these older physicians that would come back and help, but the hospitals want to keep the doctors who are already on staff, force them to work more hours rather than bring in these new physicians, because it costs less to just have people work more hours than relieve them by bringing in new, fresh physicians who are eager to help. And this physician said, all we need is some time off. We just need like a day or two to what normal people get every weekend. We just need a day or two to recharge our batteries, and it would be so helpful. But
yes. And I think that the electronic health record has played a huge role in just occupying so much of the physician's time, especially in, more of the face-to-face patient care specialties like family medicine and internal medicine and OB-GYN. They talk about the pajama time at night,
right?
With the electronic medical record, trying to catch up with, what they weren't able to get done during the day. And,
and it's why we're losing so many physicians because they just don't want to deal with these records, the system that isn't very physician friendly. It wasn't designed for physicians, for the medical field, so it's just not working. So many physicians are just opting out of medicine rather than learn these new systems. And then sometimes the systems change. So then you have to learn a new system on top of that.
And Atul Gawande talks about how physicians are the most tech avid of professionals. So, so I think the fact that this very dysfunctional electronic medical record that really was designed for billing and coding, it was designed for capturing revenue for the institution. And it makes charting on the patient and recognizing the patient very difficult. You get just pages and pages of, cut and paste kind of template that you can't process visually.
Yeah. You have to check all these boxes. So, there you are, you go to see your doctor, and the doctor has his or her face buried in this computer, checking off these boxes,
right?
Making sure, there's compliance, or else, they may not be able to prescribe the drug that they want, or they may not get credit, paid, reimbursed.
Have you been talking to people about COVID-19 and really what has this revealed about our medical system and our healthcare systems?
Yeah, I mean, it's really exposing the inadequacy in the system. And not only that, what's really troubling to me is it's really exposing the lack of care and concern that hospitals have for their workers, for their physicians, who are charged with precious life.
Right.
So it's really exposed that, so many physicians on the front lines of, compared it to it's like a third world country healthcare in what should be a first world. So, not having adequate PPEs, face masks, fighting over N95s, trying to get it. I know a friend who's got one. He's going to send me one. I mean, I had my mother and my sister and nephew were gluing together, masks with shields for the local hospital. And I said to them, this is crazy. That you're having, the Boy Scouts making thousands of masks for healthcare workers. I mean, and so how does that make the physician feel who's on the front line that they're fighting, to just have adequate protection so they can do their jobs?
I think it's been shocking. I think the public has really got their eyes on something they were not aware of, which is really this contentious almost relationship where it seems like the administrators of some of the systems, I mean, some are splendid, but some of the systems advising their staff and their physicians to not scare patients by protecting themselves. Don't wear your N95s because it might make patients concerned that there's something wrong. Really
Right.
sacrificing their own workers, their own professionals and staff to an image concern.
Here in Los Angeles, there were, was it 9 or 10 nurses that were suspended because they refused to care for COVID patients without an N95 mask. Other workers got them, but they didn't. And they said they need that. And they were marched into the administrator's office and told, if you are refusing, you are abandoning your responsibility. And so they suspended them.
Shocking.
Yeah.
Yeah. I mean, it's really bringing into sharp relief some inherent dysfunction. In one of my podcasts, I talk about there's a permission in some systems for administrators to have antipathy towards physicians for that. And it's like, how can that be a thing? These are the core workers. This is how you get your hospital door opened, is by using a physician license. How is it possible to have it be a thing that there can be disregard or disrespect for physicians within the organization?
Which brings up an interesting point. If you're going to work on an assembly line, because some hospitals have become that, some of these big box clinics, if you're going to work in this kind of atmosphere, don't you need representation? Don't you need someone who has your back? When I travel around the country, the number one thing I hear from physicians is that I'm powerless. I have no voice. I have no contract, power. I have, I'm an island here. So, and the administrators are not physicians. They're business people. They're bean counters. They don't really have any kind of empathy for the physicians. So, I probably would get fired. Thank goodness I can't get fired, Patty, because I'm sure a lot of things that I've said here today, physicians are feeling and thinking, but they would never dare. There's so much retaliation in medicine.
Well,
so
we've seen it. We've seen it with during the COVID-19 crisis with physicians. There was a physician up in Seattle, Dr. Ming Lin, who was trying to stir up some PPE for his staff, and he was fired. So again, here's somebody trying to protect other people, and was terminated from his job for that as a ED physician.
I mean, you hear about that like in China.
Yeah. Yeah. It's amazing. And I think you and I have a little different take on the idea of physicians needing a voice and needing protection, as opposed to the idea of representation or unionization. My point of view on this is of all the traditional, classic traditional professions, law, engineering, medicine. Medicine is the only one that doesn't lead its own profession. So the big international law firms are led by lawyers. The big, international engineering firms, even if they have 100 business groups, they're led by an engineer. And at some point, physicians abdicated leadership of healthcare, and it's a complicated past. But in my opinion, and I think it's backed up by research, a lot of Amanda Goodall's research on leadership, we need physicians to be leading in healthcare at every level, and that's the voice that we need.
The reason they don't is because they are so busy, doing their rounds, seeing, 40 to 80 patients. So it's difficult to find the time to become leaders. I mean, you barely have time to get home to your family, have dinner. And as you said before, many are going home to chart. So where is the time? So many would want to become leaders, but they just are so stretched as it is. They are just wiped out. So it's like adding and I know we disagree a little bit on this, but that's okay, because I think you need both. I think we need physicians to step up, and I think we need to do it with hand in hand with patients.
Yes.
At the same time, they need someone for contract negotiations, which also protect patients in some ways, because if you have exhausted doctors, you're not going to give good quality care. Right. So this benefits patients as well. So they need a voice. If they're going to be sitting across the table from business administrators and attorneys, they need that kind of support on their side of the table. It's often just them with, administrators when it comes to renewing contracts. So,
yes,
I know it's a taboo word, union, but, because physicians, it's a calling. Right. But, if we look at the trends in healthcare with the corporatization of care, with these huge healthcare systems, well, we need to say it's time for change. Just like medicine has been very reluctant to change just because, the acuity of care has changed, but medicine hasn't changed along with this acuity of care. We have to also look at the changes needed when it comes to having a voice in these negotiations to protect yourself and your patients if you're dealing with corporate executives.
Right.
So it's just a time that may have come.
And I think that the idea of really understanding what's written down, that is an absolute theme for me, for physicians to understand the contracts, whether it's their own, contract with an organization or even the bylaws and, the policies and procedures of the organization, and what is written down about the accountability and authority of physicians, because there is most likely quite a mismatch between what's actually happening and what's written down in the bylaws of the hospital, where you can bet that any medical organization, any hospital, healthcare system, or clinic, if there are bylaws with regard to employed physicians, it's going to say that they have autonomy to treat patients as they, as they want to. The language will most certainly be protecting physicians' autonomy, and I'm not anti-union, but I feel like physicians should be in a position to understand unions and meet with representatives of unions in order to be more supportive of nursing staff and other staff who are members of the unions. So I don't think that physicians should regard themselves or put themselves out there as anti-union. I think we should be hand in hand with the unions that do provide protection and coverage for the nursing staff. But physicians should be leading the organizations, and unionization is not for managers and for leaders. It's really for people that need protection. So it's making that transition. It's how do we really make a point to get physicians more and more into positions of leadership, because that is a patient safety issue. There are better outcomes in that small percentage of healthcare systems and hospitals that are led by physicians. They have better quality outcomes.
But, you have to remember how we got into this mess in the first place with managed care, back during the Nixon administration. So, there was a definite need for caps on fees because they were astronomical, and there was a large amount of greed that was going, unsupervised when physicians and hospitals didn't have any kind of oversight. So if we want to return back to this strong physician-patient relationship, well, we need fairness,
right,
in fees, transparency. We don't want, patients being referred to other doctors, specialists. You wash my back, I'll wash yours.
right.
Sending them for unnecessary tests and all this just because it benefits them in some financial way. So we need to take that burden away from physicians to generate income in that way. They don't want that. As you know, I mean, you never went into medicine to see how much money you could make. If you did, you should have been a business person, because
Absolutely.
certainly every physician is smart enough to be a business person, do whatever they want to do. So you're not in this to generate as much money as you can for your practice. So we need to take that burden away, that pressure, the financial pressure that a lot of physicians feel to bring money into their clinic. And we would need fair fees and transparency.
Absolutely. I completely agree with that. And we don't need to return to the abuses of the past. That's
right.
That is absolutely the truth. Well, how wonderful having a chance to talk with you, Robyn. I really appreciate this. And I was going to ask you one other question. It seems that you have probably developed quite a relationship with Dr. Pamela Weibel. The 2 times that I've talked with you, Pamela happened to call you even as you and I were talking. So I'm so curious about that. Tell me about you and Pamela.
Well, when I was researching physician suicide back in 2014, her name popped up all over the place, on the internet. So she was one of the first people I reached out to. And she was able to connect me with some med students and families, because she runs a hotline, a suicide hotline. So she has a very large following of physicians and med students. But there were many other experts, in the film that I used and wove through the film, as you saw. But right now, with, the social distancing and everything being shut down, we've sort of pivoted from these live events that I love doing, and I love being there, to bring the community together. But we've had to pivot to these virtual screenings. So we had our first one April 19th, and we had like 5,000 people come to the registration site, and we had 600 attendees in the screening and then in the on-demand. And so Pamela Weibel and I said, we should do this every Sunday in May. It's Mental Health Awareness Month. So we have every Sunday evening, 8 p.m. Eastern, 5 p.m. Pacific, every Sunday, a different topic following the film screening, and with Q&A where you can ask anonymous questions if you want.
Excellent.
So we've been, inviting panelists to join us so we can have a mix of experts with us every week. We're going to be talking about legal matters, lawsuits, legislation. So every week, if they go to www.donoharmfilm.com, they can see the whole schedule now on the homepage. Great. And sign up to register. So I'm really excited about this series, and I really see it engaging so many people while we're all, at home.
Yes. Well, we're all sheltering ourselves at home.
Shelter in place.
I really have very much enjoyed this conversation, and really honored to have you on the podcast. Again, people can go to donoharmfilm.com and click on a register button and sign up to view the film and witness the panel discussion as well. And people are also invited to send in questions, anonymous questions that can be answered by the panelists after the film. Is that correct?
Yes. And thank you so much, Patty. It was a wonderful interview. You're amazing. Thank you for inviting me. I really appreciate it. You do great work with your podcast.
Oh, thank you so much, Robyn. I really appreciate the film, and I think it's so valuable and important. And I hope we get a chance to see each other in person sometime.
Same here. Okay. I would love it. Looking forward to it.
All right. Take care. To learn more about how we work with physicians and other leaders to create healthy work cultures, or to join in the conversation for future podcasts, go to licensedtoleadpodcast.com, where you can send me an email or leave me a voice message.